I'm Joyce O'Shaughnessy. I'm at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. One of the questions that virtually every woman or man with early breast cancer asks me at the conclusion of either their preoperative therapy and their surgery with or without radiation, or if they have surgery first and then they get chemotherapy or endocrine therapy after surgery. Once they're finished their therapy, pretty much everybody asks me, how are we going to monitor me? How are we going to make sure that I am remaining cancer-free, at least as we can tell cancer-free? Because our big limitation right now is we don't have any tests, for example, blood tests or any imaging test that can really pick up microscopic residual disease. There's a lot of work going on that, but we don't have that in hand right now. But patients are very interested in knowing whether or not they have any evidence of disease that's obvious with regard to metastasis. So first of all, we'll turn to our national guidelines, ASCO and NCCN, and neither of these expert panels recommend any kind of scan monitoring or blood test monitoring after the completion of therapy for early breast cancer in the curative setting. So no CT scans, bone scans, regular blood work, for example, looking at the bone marrow, bones, liver, and also no tumor markers, for example, the CA2729 or the CA15-3. And well, why is that? And the answer is that heretofore, as of today, we don't have any evidence that monitoring with scans or monitoring with the tumor markers will translate into more cures for patients. So the idea would be that if we could pick up the cancer early, like one bone metastasis, for example, that we could then have a better outcome and cure more women because they have more minimal disease if we give the therapy, right away to a woman or man with a small amount of disease, that is a chance of curing that patient with metastatic disease, as opposed to if he or she shows up, a year later with 10 bone metastasis. So that question has been put to a number of randomized trials where mainly women with early breast cancer finish their treatment, have been randomized to receive regular scans 2 or 3 times a year versus just being monitored by careful physical examination, careful history taking, where any findings on the history or the physical, anything that's not right, is then followed up with the appropriate scan. So that's the randomization. Scans without symptoms or scans based on symptoms or physical exam. And the same thing has been done with tumor markers, monitoring the woman with tumor markers versus not monitoring her, and monitoring her on the basis of her physical exam and her history. These have been randomized trials to see whether these tests improve survival, improve the cure rate and the overall survival for patients. And the answer is they unfortunately do not. So you can pick up metastatic disease 6 to 9 months earlier if you do serial scans or serial tumor markers. But unfortunately, if you start the treatment of that metastatic disease picked up on scan or markers 6 to 9 months earlier, then if waiting for it to show up in the blood work or show up as a symptom, and then you start the treatment, at the end of the day, one group is on therapy longer for their metastatic disease and is having side effects from that treatment, but that group of women does not live longer, having started metastatic therapy 6 to 9 months earlier. So that's the unfortunate reality that we have right now, is there's no real benefit in it for patients, and there is a downside. A lot of scans will pick up incidental findings that then require serial scans to make sure nothing has changed, or may require a biopsy to make sure something isn't metastatic disease. The tumor markers can vary from one blood draw to the next and create a great deal of anxiety and lead to a lot of scans, again, that expose to radiation, cost, time, anxiety, etc., unnecessary biopsies. So there is a downside to scanning. So I always tell my patients that what I do is careful physical exam, careful history. Most women do end up getting blood work once a year from their primary care physician. They may get a chest x-ray. Any test that they get as part of their well woman care, I certainly want to see them. Of course, they'll get mammography, etc. And as long as everything is fine, then we don't need scans. But I have a low threshold. If any woman has any symptoms, anything she's been concerned about, if the physical exam is at all equivocal or blood work's at all equivocal, I have a low threshold for getting scanned. So I kind of joke with my patients. I say, be careful what you tell me, because we'll be scanning it. So that tends to reassure women that we're not going to be overlooking things that we should be on top of.